Hello, and welcome to the first part of our trauma-informed care series for volunteer supporters. This is Foundations of Trauma-Informed Care. My name is Laura Collins. I'm with Health Management Associates, and I will be introducing our speakers. Go to the next slide. Today we have Dr. Karen Hill from Health Management Associates. Dr. Hill is a nurse with more than 15 years of experience with adverse childhood experiences and trauma-informed care trainings, implementations, and evaluation. Dr. Hill has worked to help organizations provide trauma-informed care and crisis prevention and de-escalation techniques-based training through an evidence-based culturally responsive models. And prior to HMA, Dr. Hill worked as an interim vice president of programs at the University of California, San Francisco, Glide Health Services, where she focused on patient care and safety, providing evidence-based and patient-centered care. And we also have with us today Dr. Judy Martin Holland from HMA as well. And she has more than 20 years of experience in education and collaboration with a drive to advance diversity, equity, and inclusion. Dr. Martin Holland is an accomplished, mission-driven nurse executive leader. And prior to HMA, she worked as the Associate Dean and Graduate Program Director of Master's Entry and doctoral programs in nursing, after which she served as the Associate Dean of Diversity, Inclusion, and Community Outreach for UCSF School of Nursing. Let's go to the next slide and talk about the agenda today. So today we are going to discuss the following. We have two parts. We'll start with the background and foundations of trauma-informed care. We'll be discussing social and health equity in vulnerable populations. We'll discuss why a trauma-informed approach is especially important for the care population, and we'll be introducing a case example for you today. Then we'll be defining trauma. So we'll introduce the definition of trauma and trauma-informed care. We'll discuss the impact of trauma on neurobiology and behavior, and provide an overview of the trauma spectrum, adverse childhood experiences, and levels of trauma. And then finally, we'll be discussing the impact of implicit bias on trauma. So our learning objectives today are the following. So at the end of today's session, we're hoping that participants will have an increased ability to describe the impact of trauma and implicit bias on healthcare for CARE Act respondents, to explain the impact of toxic stress and trauma on the brain, and to identify two trauma-informed care behaviors, at least two, that reduce the negative impact of stress and trauma. So now I'd like to hand the floor to Dr. Judy Martin Holland to talk about background and foundations.
Hello. So I'm Judy Martin Holland, and you've heard a bit about my work as a nurse, as a provider, a nurse researcher, educator, and clinician. Let me also share I was born and raised in Berkeley, Oakland, and the San Joaquin Valley. I volunteer in my local community, so I certainly appreciate you for getting approved as and taking on the role of volunteer supporter for the Care Court. We certainly hope that you will find these trainings informative and of value as you take on this incredibly important role. In this training, we are going to dive into trauma so that you can better understand the experience of care respondents. And we'll begin by introducing an approach to supporting individuals who have experienced trauma called trauma-informed care, or TIC. Our next training session is going to explore further the goals and principles of trauma-informed care and what it looks like in the context of Care Court. So let's get started by talking about social health and health equity. The word equity has two common meanings: fairness or justice in the way that people are treated. Most commonly used, that's what we're talking about here, that definition of equity. And then there's the financial definition of equity, which means ownership. In several ways, both definitions apply when we talk about health equity. Care respondents deserve to be treated fairly, and they deserve to feel that they have ownership of their health. Looking at this slide, you'll see that California defines health equity as the ability to have full and equal access to opportunities that afford people the chance to live a healthy life. However, when you look at the graphic on this slide, you'll see that there are a number of factors that influence a person's life that are not fair. And these factors are those that you, me, and the care respondent has no control or ownership over. The state of California realizes this, and in order to develop health equity in our state, an Office of Health Equity was established. This office was authorized by Section 131019.5 of the California Health and Safety Code. The charge of the Office of Health Equity, is to provide leadership in the reduction of health and mental health disparities experienced by vulnerable communities across the state. So now let's talk about communities at risk. As you may be aware, there are certain communities and groups of people who are commonly experiencing inequities. They have insufficient or limited resources or capacity to protect and promote their health. We like to refer to these groups as communities or people of promise because we believe that with proper support, protection, resources, and understanding, they could thrive and move forward with improved health and wellness. These groups are women, racial and ethnic groups or minorities, low-income individuals, people with mental illness, people with substance use disorder, seniors, youth, those with limited English proficiency, people who identify as LGBTQIA+, people with intellectual disabilities, immigrants and refugees, and people with physical disabilities. Now, we recognize that care respondents must be age 18 or over, so the group community has been set aside as we talk about the care respondents in our trainings. But keep in mind, adverse childhood experiences from our youth will impact how we process stressful events well into our adult years. We will talk more about adverse childhood experiences in our next training. To illustrate care respondents may be part of many communities of promise, let's meet Angela. Sometimes it's helpful to have a fictional case for us to consider as we discuss trauma-informed care and the CARE Act. Today, we are utilizing a fictional character who we are calling Angela, and a fictional case to help us illustrate some of the terms and concepts presented in this training. She is not real, but her situation may sound very familiar to you. We are going to go over different aspects of trauma and illustrate how that can impact care respondents. We will revisit this case example as we discuss trauma. So who is Angela and what is her situation? She's a 46-year-old woman, estranged from her two children that are ages 17 and 22. They are not on good terms. Perhaps this is due to Angela's mental health condition, living situation, or perhaps her partner. She has a history of early adversity. She lived in a home in which her father was absent, and she lived with domestic abuse in the home. Spanish is her first language. Angela has schizoaffective disorder. She also has type 2 diabetes and high blood pressure, and she smokes cigarettes. She is currently hearing voices and experiencing paranoia. She is not currently connected with mental health or taking any medicines or taking part in any medical treatments. Angela is in an abusive relationship and has experienced numerous assaults. She's been evicted from low-income housing related to her symptoms and intermittently stays in shelter, and that's where she is currently. She's been hospitalized in the past 4 months on a 5150 hold. A 5150 hold refers to a 72-hour involuntary psychiatric hospitalization. This happens when someone is evaluated and found to be gravely disabled or a danger to themselves or others. A family member filed a petition for care court, and through the court and behavioral health assessment process, she was found to meet the eligibility criteria. The care court approved Connie, a longtime friend of Angela's, to be her volunteer supporter. Next slide, please. Consider the eligible population for the CARE Act. Individuals who are experiencing a severe mental illness with severe and persistent symptoms, persons who are unlikely to safely survive and are deteriorating overall. Think about Angela and her situation. Respondents in the care process are likely part of more than one community of that is vulnerable to social and health inequities, along with trauma impacting their health and well-being. Trauma-informed care recognizes the signs, symptoms, and impact of trauma, and the approach promotes recovery and equitable care. It is essential to have a better understanding of trauma and the benefits of trauma-informed approach, which can help you better understand how to support this community. A trauma-informed approach will help you as a volunteer supporter. No one denies that supporting these individuals who are experiencing very debilitating illness can be difficult and challenging. So it is important that you have empathy and compassion, both for them and for yourselves in the process. Let's talk about the numbers you can see here, describing persons who may be eligible for care. Over 122,000 California residents are in state prisons, with an incarceration rate of 310 per 100,000 Californians. 30% of the 582,000 unhoused individuals in the U.S. reside in California, with at least 25% of those individuals living with a serious mental illness. Slightly over 17% of adults are living with a substance use disorder in California, and 15.39% of them need treatment in a specialty facility for substance use disorder, but are not receiving that care. Consider that one study found that 82% of respondents with mental health concerns had experienced very disturbing interventions, such as police transportation to treatment, being placed in handcuffs, being involuntarily committed, secluded, restrained, and having forced medication. Anyone experiencing any of these disturbing interventions would find it to be traumatizing. Next slide. Consider the ways in which social and health inequities have a huge impact on vulnerable communities. How could this impact care respondents such as Angela? Some of what they are experiencing could be a lack of mental health providers and a lack of healthcare in general, long waits for healthcare, unsafe living situations, and I suspect Angela is living with food insecurity. In addition, people without income to live are often forced to be in environments with more drugs, crime, and violence that puts them at higher levels of risk. Again, consider Angela and other women who at times find themselves living alone on the streets and hearing voices. Karen, what are some of your thoughts about how care respondents may be impacted?
Thank you, Judy, for that. I want to just acknowledge that we know that Angela's situation is complex, as are many of our care recipients. Angela's at risk for being assaulted, robbed, raped, and possibly death. It's not uncommon for individuals to be targeted on the street or dismissed by our healthcare systems. Angela's overall well-being is impacted due to substandard social and healthcare issues. For example, housing, long waits for mental and physical health care, provider access to safe housing and nutritious meals. This is a very difficult situation that really takes all of our attention. You know, we've talked a lot about trauma. So now I think it's time for us to really define trauma. What is that? Before I do that, though, I'd like to introduce myself. I am a nurse practitioner with over 30 years of experience. I lived in California all of my life, spent about 15 years managing a community health system where we actually had an integrated model of care. 90% of our population struggled with mental health issues, substance use disorder, and unstable housing. So this promise population is near and dear to my heart. Let's talk a little bit about our background. Well, first I want to talk about trauma. In our last section, we provided some foundation for understanding trauma and trauma-informed care and why the care population is extremely vulnerable or at risk. In this section, we're going to explore trauma further and better understand the experiences of care respondents. So let's go to the next slide to background. Thank you so much for that. So let's start by defining two important terms. The first term is trauma, and we're going to use the Substance Abuse and Mental Health Services Agency, or SAMHSA, definition for trauma. It's here on the slide, but I'm going to read it for you because I really want you to hear some key words that are actually bolded on the slide. Trauma results from an event, series of events, or a series of circumstances that an individual experiences as physically or emotionally harmful or threatening, which may have lasting effects on the individual's functioning. Their trauma can affect us, and we also consider this, how trauma affects us. We consider these the 3 E's: the events, experiences, and effects. You see those words highlighted. Trauma is what happens inside of us as a result of those 3 E's. I want us to remember and to note, we are not our trauma. And so we don't want to take that on as a mantle. And so people experience this, but we do not become our trauma. The second definition is trauma-informed care, which is a set of principles that reinforce a culture of safety, empowerment, support, collaboration, cultural humility, equity to promote this healing and builds resistance. The key to trauma-informed care is acknowledging that in order to promote all of these types of health, including mental health, we must try to understand the context that our respondents are coming to us with, as much as they are willing to share. People do not have to share all of their trauma with you in order for you to really provide trauma-informed care or have a trauma and care approach. We're going to interchange those words, approach and care, together. Another important key thing is to remember that trauma-informed care shifts the focus from what's wrong with you to what happened. We acknowledge that our experiences have a profound effect on our physical, spiritual, and mental health. Trauma changes. The experience of trauma, it changes our world view. Let's go to the next slide, please, and talk a bit more about those 3 E's. It's really, really important as we think about Angela and all that she's experienced in really her young life. Angela has experienced abuse. She's a survivor of domestic violence and abuse as a child and as an adult. She has been evicted from her home and housing. Let's just think about that and let that sit with us. Angela has likely experienced all types of bias. We're going to talk more about that a little bit later. Often maybe due to her language, maybe her mental health condition or her presentation when she is not in good control with her health conditions. Angela's been held involuntarily, maybe not even understanding the context of why she was being held. What could she experience? Her physical and emotional and harmful and threatening. Angela could be fearful about authority, particularly men. We might not even be clear about who the abuse came from. It might not be men. She might just be afraid of people in general. She might be reluctant to voice her preferences in her language, be fear of being made fun of or being understood. She might be worried to discuss her symptoms because maybe she's going to be put on another psychiatric hold. So we can understand how those events and experiences can affect us. Angela might get anxious when she's in a room with other people. She might be distracted if she goes to court or in the hospital or when police come around in official buildings. It might re-traumatize her. Angela could stop voicing her opinion and her preferences when she feels like she's being confronted. And she could get angry and lash out, and that might really be misinterpreted. Surely we don't know all of the issues that have led to Angela's current situation, but we do know that her traumatic experiences and her learning life experiences have impacted her in real ways. So let's look at the role of cortisol in this whole trauma experience. Cortisol is a hormone that your body really releases when you're stressed. One thing to keep in mind is that trauma and toxic stress can actually change your body at the cellular level. All of our bodies release a hormone called cortisol when we're confronted with a stressor. Scientists have discovered that the biological system in our bodies that was really designed to preserve our lives when we are confronted with a stressor, if it's constantly activated, then begins to harm our body. And you can actually see on the slide what cortisol does. It increases our blood sugar, maybe leading us to have diabetes, suppresses our immune system, making us sicker and more vulnerable to colds and flus, affects our memory and our attention span, because when this cortisol is activated, actually our thinking brain shuts off. We go into survival mode. It decreases our sensitivity to pain and it raises our blood pressure. So we don't really want that activated all the time. Let me give you an example. If you were to see a really big, angry dog baring its teeth and running down towards you, or a bear charging at you, ready to hurt you, your body is going to release massive amounts of this hormone, cortisol, that makes you either freeze as a protective method, fight as a protective method, or run. Your blood pressure goes up, your blood sugar goes up, you get more energy to try to protect yourself. When your body is stressed, your heart pounds faster, all of those things happen. It's your alarm system. Then, after the threat goes away and you receive adequate support, your body returns back to normal. Unfortunately, with many of our clients in the situation of Angela, unresolved trauma continues to happen. Help never comes. And that's really the problem. And that's when it starts to become dangerous for us. And that's when it makes us sicker. So we think about patients respondents or individuals like Angela. People often start trying to calm themselves or their feelings without proper support by smoking. They might eat more. They might use substances. In other words, people compensate in ways that may not be healthy for us. And those are the things that can make us sick. As a volunteer supporter, it's important to try to help in the moment. You might be asking, what can I do? What can I do? The most important thing to do when somebody's trauma is activated and that system is going and they're in that fight, flight, or freeze mode, try to remove them and put them in a safer place. You might want to get them away from whatever's making them feel traumatized. You might try to calm the area down, ask them if they want to take a walk, maybe have a drink of water. These are all things that lower our cortisol and help people return to normal. Remember that in addition to their serious mental illness, the trauma care recipients also have these experiences that have impacted their brain's ability to cope. You may be frustrated with how they react and how they make decisions. There's a lot of factors influencing their behavior, and some of their responses, this fight, flight, or freeze, and that cortisol being activated. We're going to talk more about this a little bit later. It's important for volunteer supporters to remember people are not trying to be difficult. They're doing the best that they can in the moment. Our job and your support means that we try to understand without bias and blaming, identify their triggers, try to plan and use some tools that we'll be giving you to sort of calm them down and lower cortisol, to return them to a normal state biologically as soon as possible. I know that's a lot. We're going to now move to that stress response and talk a bit more about that fight, flight, or freeze. What does it look like? If we don't know about the biology of trauma and how we react when our system is activated, it's easy to misinterpret these stressful responses to the situation. Our brain's ability to reason disengages, and we're more likely to be, angry and want to fight or want to run, and those can really be misinterpreted. So, for example, if somebody is traumatized because they're going to a court or a care court, or they have a provider to see, and it reminds them of some negative experiences that Angela has had, they might try to fight. She might try to fight you. And we might interpret that as, being non-compliant and combative, when in fact, it's the individual really trying to gain power and hold their own power. they may run or not even go to the medical appointment at all. And that could be misinterpreted as that they're disengaged emotionally and they don't really care about their health. That's not true at all. We mislabel people without understanding the true concepts of the neurobiology. And then finally, you might be talking to someone, or there might be in a meeting and they're sitting there almost in a state where they're not moving and not doing anything and just sort of sitting there and not responding at all. And it looks as if the person is, passive and unmotivated, when in fact they're in that freeze mode. So this is how these protective mechanisms show up when the fight, flight, or freeze system in our bodies is activated. We've defined trauma. We've talked about the stress response. Now let's move and talk about the different types of trauma that people often experience. So there's a whole array of trauma. We're just types of trauma that people can experience, and we're just going to touch on a few. Some of these really, as volunteer supporters, you're at risk for as well. That first one is vicarious trauma. That's really when, the trauma that you feel from being constantly having exposure to working with individuals who have trauma and complex trauma. There's compassion fatigue, and this happens sometimes with carers or volunteer supporters or people who are supporting people who have very complex lives, where it's the chronicity of the stories. You hear it over and over and over again, and it just begins to wear on you emotionally, and you become emotionally fatigued to all of the problems that people have. There's secondary trauma. That's really comes from the exposure to working with individuals again, and so that vicarious trauma, secondary trauma, and compassion fatigue, all kind of are issues that can be affect our volunteer supporters. I've used that term complex trauma a couple times, and I want to actually define that for you. That is emotional dysregulation. That's a big word. It's really the unstable emotions. People who have lots of trauma where they're not able to, they go from 0 to 60. They're laughing 1 minute and they're crying and ready to fight in the next minute. They can't really regulate their emotions. They might have lots of problems interpersonally, difficulty communicating. Their family relations are disrupted, low self-worth, and just prolonged issues of trauma. We have that insidious trauma, and it refers to sort of the daily incidences of feeling marginalized and objectified, or people are looking at you and making comments about your gender or your ethnicity or your race or your size or whatever. You just feel like you're not even human and being intimidated. All sexism and oppression. Many of these things can result in toxic stress, and that's really a response where that activation system that I spent so much time talking about is constantly on hyper alert. That is really where your cortisol is always high and changes biologically. We're calling that toxic stress. Just a couple more here. Acute trauma, that's an assault, a car accident, even a surgery that people can experience. And then that chronic stress where it's just always something that happens. And, we have individuals who experiencing these things over and over again. I'm going to take us right back to Angela. We're going to go back to her and think about this again. Angela has disclosed so many things to us. We know she's got complex trauma. She's got the chronic issues of trauma. She's been assaulted, so there's maybe a acute trauma. And she might have a familiar history of historical trauma. That's where perhaps she came from a war-torn country, or maybe there was a natural disaster and she had to leave and come to this country, or perhaps her family. We carry all of that in our bodies. We're going to talk now about early adversity, adverse childhood experiences, or the short term for that is ACEs. We wanted to discuss early adversity and adverse childhood experiences, a specific type of trauma that occurs between 0 and 17 years of age. And you might say, 0? How can that happen if I'm not even born? You know, the unborn child carries really and takes on the issues that the mom has. If she's constantly hyperstimulated and that cortisol is running through her veins and in her bloodstream, unborn baby is getting that. So this is something to think about. Early adversity, we now know, has lasting effects that are significantly impact an individual's life. As we noted earlier, the care population includes adults over 18. However, as my colleague, Dr. Holland Martin said to us, we know that they have long-lasting effects. About 30 years ago, the Kaiser study looked at 17,000 individuals and in their ACEs study, and they found some really, really groundbreaking information. The ACEs are common across all populations of people. Almost 2/3 of the study participants reported at least one ACE, and more than 1 in 5 reported 3 or more ACEs. And the higher your ACE score, the more at risk you are. Remember what I said at the beginning, you're not your ACE score and you are not your trauma, and it puts you at risk for higher, greater problems in your life with your body, socially, and emotionally. Some populations are more vulnerable to experiencing ACEs due to their social and economic conditions. And the ACE experience or having ACEs increases negative outcomes, as I've said. From that research, we know that there are ways and there are things that we can do that we're going to talk about that can help reduce the long-term negative outcomes. But on this list, I want to just talk briefly: family violence, parental divorce, having mental illness in the home, experiencing physical or sexual abuse, emotional abuse, neglect. There's not enough food in the house or nobody pays attention to you. Substance use disorder in the home, having a parent that's been imprisoned, food insecurity, housing instability. All of these things affect our lives and our home life. It's an interesting thing to notice how, as we think about Angela, she's experienced all of this early adversity, and yet she seems to be repeating much of this in her home life with an abusive partner. This is a very common occurrence. If there's not some intervention or support to reduce and have individuals recognize how the trauma has affected their lives. Let's go to the next slide and talk a little bit more about the trauma experience and how it's at the individual and the global level. We can see here that individually, it's those ACEs we just talked about, our parental having alcohol addiction or incarceration, community violence. These are things that you might not even have any real influence over. You live in a community where there's a lot of violence. It might not even be in your home. Commercial sexual exploitation. Perhaps you go to a school where there's a lot of bullying or school violence, or you might have a partner in school that's hurting you. And then on that global level, political violence, forced displacement, natural disasters, economic downturn. We now know that across the world, people are being forced to move just because there's not enough food, water, or climate changes. All of these are things that impact people and stay in their lives. Let's go on the next slide and talk about the impact of trauma. It affects us in every single way. Our emotions, our behaviors, our physical health, how we develop, our minds, how we think, how we interact with other people, our spirituality, and certainly our economics. As much as we may dislike our early adversity and or trauma, we commonly see its influences play out over and over and over. And this is why it's so important for us to be able to understand it and provide resources for people to get help. So we see people avoiding situations, not able to manage jobs, having a lot of family disruption. And so what we see is if this happens to us as adults, as children, these adults grow up and the system is actually continued in their families. And then we have children who then are experiencing it. So we often sometimes think of trauma, it can be passed through generations, intergenerational trauma. Let's go to the next slide and look at some of the symptoms and things that we see. What does it look like? I've talked a lot about trauma, how it affects people. So what does it look like when it's triggered? The trauma response of individuals can be really difficult to manage, can be difficult to tolerate, and can even result in more trauma if people don't know what's happening or how to respond what's happening. In addition, it's also, we have a list of things that we see, but everyone is really different and it's individualized. But we do see in lots of ways, people sometimes have difficulty with stressful situations and change. They have difficulty managing when a schedule change, and that really frustrates them. They can exhibit attention-seeking behaviors, meaning acting out in public. They can be overly guarded. If their stress response is activated, they scare and startle very easily. They get mad very easy. Can maybe forget things. You can tell somebody something and 2 minutes later, they've forgotten what you've said because their attention to what you're saying is disrupted. And so that leads to other behaviors. They miss appointments. They often can maybe not take care of their physical being and take care of themselves. They seem to continue to be in abusive relationships, can hurt themselves. And then again, we see substance misuse and relapse, because it can often be a way for people, once they're activated, they'll start doing things to make themselves feel better if they don't have any tools in their toolbox that can help them. So as a care supporter, it's important for us to understand what possible triggers are for our care respondents and to be able to have some ways that we can immediately help them in the moment. And we'll talk a little bit more about that. Let's talk about the complexity of this. We know that we've seen Angela. She's got lots of issues, very difficult situation to deal with. Supporting individuals with current or past or re-traumatization can be very difficult and complex. As a volunteer supporter, your role is to try to diminish the effects of trauma. And how do you do that? You do that by supporting them, getting help when needed, demonstrating empathy, and using trauma-informed skills and trying not to re-traumatize. people to the best of your ability. We know that working with these individuals with all of these issues can be stressful for volunteer supporters. So it's equally important for you to take care of yourself and to make sure that you can help your respondents. Trying to maximize opportunities to move toward wellness and self-advocacy is really the role of the CARE Act and the role of volunteer supporters. It can be a difficult and stressful work. Judy's going to now discuss how bias impacts all of this work. Let's go to the next slide, please.
Thank you, Karen. So bias is a trauma. We can traumatize one another through our biases. Bias is an example of trauma that we impose on one another. So let me explain. First, it does not matter who you are. Everybody has biases. If you are human and you're breathing, you have biases. Some biases are positive and helpful, such as choosing to eat only foods that are considered healthy, or keeping you away from something that has knowingly caused harm. Let's say you've been bitten by a rattlesnake. You probably don't want to see another one, right? And when you see one, you walk in or run in the other direction. This could also include a person wanting to get away from or be out of the presence of a person who has knowingly caused harm to you or to people who are like you, like an abusive partner. Those are the type of biases that are helpful because they keep us safe. Implicit bias is a form of bias that occurs without intentionally thinking about it. If we are intentionally thinking about it, I hate snakes, for example, then it's a conscious bias. But implicit or unconscious bias occurs when we are not consciously or purposefully thinking about it. Here's an example. Say I move to a new city, and I only seek out those who look like me to learn more about the area. I may not be consciously aware that the only strangers that I speak to either look like me or are similar to me. But if someone points it out to me, then I recognize it. It was unconscious or implicit at first, but then it was brought to my attention. So now it's a conscious bias. Now that I'm aware of it, I can choose to do something about it. Unconscious biases are most dangerous when they are applied to people who do not represent harm to us. We use our bias to make assumptions about another person, what they represent, what they can or cannot do, what they can achieve, what their motives might be. These assumptions are usually based on our unconscious biases, but it could be based on our conscious bias as well. What's even more important to recognize, however, is these types of biases are usually based on stereotypes. It's not necessarily something that we get from understanding the actual knowledge of a person. Getting to know someone as an individual usually reduces stereotype-based biases, because then we understand that person and or their circumstances. But when we make assumptions about who they are or what their circumstance is, that's when we're employing stereotypes. How else might that look? Well, some people have been diagnosed with a serious mental illness when they did not have a mental illness, but their thinking or behavior may be a response to how they're being perceived or treated by others. This is especially true when it comes to race and serious mental illness. Let's go on to the next slide. Serious mental illness, or SMI, is an area in which the implicit biases of healthcare professionals may impact their diagnosis of an individual with mental illness. In this case, overdiagnosis, meaning patients who did not have a serious mental illness were giving that diagnosis anyway. People from racial or ethnic minority groups are especially vulnerable to overdiagnosis, in particular, Black Americans. As you can guess, this leads to poor or negative outcomes for those individuals. Consider that African Americans with serious mental illness, or SMI, are more likely to be hospitalized, and individuals who are racial or ethnic minority experience more negative treatment outcomes. For example, they have fewer follow-up visits. They are often experiencing reduced improvement of their symptoms after their diagnosis, and they are offered fewer treatment options. Let's look now at the relationship between implicit bias and stigma. Now that we're looking at the relationship between implicit bias and stigma, it's important to realize that how we think influences how we behave, especially our behavior towards others. Therefore, our biases influence our assumptions, our judgments, and our behaviors toward others. Have you ever been served by someone or had somebody provide care to you that did not seem to have your best interest at heart? Have there been times in your life when even without words you sensed that someone didn't feel that you could or would be successful at something? These are all examples of sensing or experiencing someone else's implicit bias. Similarly, stigma, which is defined as a powerful social process that is characterized by labeling, stereotyping, and separation, which leads to loss of status and discrimination, places a value on individuals or groups. Merriam-Webster defines stigma as a mark of shame or discredit. This mark is a distinguishing characteristic of a person or group that is viewed negatively, such as experiencing mental illness. The shame associated with it creates significant barriers and obstacles to care. There is evidence that individuals with mental illness internalize the stigma directed towards them and their illness. This impacts both readiness to seek and participate in treatment, as well as the person's confidence that improvement is possible. Stigma is complex, and it occurs on many levels. There are three main interrelated types of stigma, and something that's called courtesy stigma, which is directed towards the family and or friends of the stigmatized person. So let's look at the three main levels of stigma. Structural stigma is based on societal conditions, cultural norms, or institutional practices that constrain opportunities, resources, and well-being for stigmatized persons or populations. Public stigma is the negative attitude, beliefs, and behaviors held within a community for the larger cultural context that comprises negative social norms. And self-stigma is the internalization of public stigma by a person with a condition, disorder, or minority status. So let's give an example of this. In many societies, public stigma could be if you are male and you have a mental illness, then that's very shameful. That brings shame upon you, and you can't possibly be a strong male if you happen to have a mental illness. In many of our cultures and in many of our communities, this negative assumption about a male who would seek care for mental illness, or even that a male may have a mental illness, is stigmatizing and employing implicit biases against males who seek mental illness. It may halt a man from seeking help or treatment of a mental illness because he feels like he has to be strong in his community. Self-stigma is that internalization. So he himself may understand that he has a mental illness and understand he needs help and should seek care, but may choose not to because he's internalized that negativity from his community. That would be an example of self-stigma. In many cases, two or more stigmatized statuses intersect. For example, race-related and substance use stigma may stop an individual from seeking assistance, treatment, or care. It increases the likelihood of discrimination and increases the burden on the individual. A common complaint among people in stigmatized groups is that they feel they are not taken seriously, or they are made to feel uncomfortable. When a person feels disrespected or experiences discomfort, they lose trust and they disengage. Trust once lost is difficult to regain. Taking a trauma-informed approach, we will discuss more in depth in the next two modules and provide strategies to you that will allow you to use a thoughtful and an intentional approach to rebuild trust. Karen, why don't you go ahead and introduce us to the trauma-informed approach?
Thank you, Judy. In this module, we're discussing the foundational ideas related to trauma. In the second module, coming after this, we're going to be focusing on principles as well, but we're just going to do a little preview here. Safety, trustworthiness, peer support, collaboration, empowerment, and the consideration of cultural, historical, and gender issues. And you might be saying, well, why is any of this important? Why are these the foundational principles of trauma and care approach or a trauma-informed care? And I would say that these are the foundational principles because for the people who've experienced trauma, such as Angela, every single one of these areas may have been broken or breached. Her simple safety in being at home has been breached. How often has she been collaborated with? You know, she was held on a 5150 and evicted from her home. Her ability to trust and people being honest with her. They may have even tricked her when they took her to the hospital. Who knows? Was she able to exert her ability to feel empowered and to feel respected? Her natural supports, whoever they are, maybe they haven't been as strong as they should be. Maybe she doesn't know how to sort of leverage those or understand that. And have people respected her cultural identity? We don't know where she came from. We know that all over the world, there are issues with gender and those kinds of things that really can be very traumatizing. Let's go and talk about a trauma-informed care approach. As we think of these principles, as we think of Angela, let's go to the next slide. It's really, really important to know what trauma informed care doesn't mean, or trauma informed approach, what it's not. It's not excusing poor behavior, justifying unacceptable behavior. Rather, we want to move towards supporting resilience, accountability, and responsibility. We want to prepare people for things that are coming up. There's no way that we're going to end all of trauma in anyone's life. There are things that are out of our control, but we can prepare respondents for difficult situations that might be coming up. It's not just being nicer. Rather, it's using our empathy, being compassionate, putting our feet in somebody else's shoes every once in a while, not being mushy or patronizing, none of that. It's really just being authentically ourselves and understanding that people come and they have the ability to come with their authentic selves. And most importantly, it's not just focusing on what's wrong with you. Remember, I said at the beginning, it's not what's wrong, it's what happened to you. It's building on skills, empowerment, and recognizing the strengths of individuals. So, in our next slide, we're going to put this all together in an ideas in action. We're back to Angela. We're back to Angela, and we want you to consider. You are Angela's supporter. She selected you. What are some components of Angela's past and current trauma that are probably impacting her now? How would understanding her trauma help you better fulfill that role of promise for Angela? So let's just think about some areas that we talked about that there's a whole list. I'm going to give you a list of groups that are often report experiencing more traumatic events. Women, for one, racial and ethnic minority groups, people who come from less resourced or low-income families, folks experiencing a mental illness or have a profound health problem, people with substance use disorder and intellectual disabilities. When we talk about physical health concerns, there are certainly some health concerns that are more acceptable than others. And people can be very stigmatized and judged because they have a certain health concern. Intellectual disabilities and people who have English as a second language. Instead of that being viewed as a strength, it's often viewed as something to make fun of. Judy, tell us a little bit more about some ideas in action of how our supporters might think of this.
Well, she also has a chronic illness. Remember, we talked about her hypertension and her or high blood pressure and her diabetes. She's been evicted as well. A terribly traumatizing experience. She's experienced abuse. She's very wary, as you can guess then, of authority figures. And she's also said out loud that she is not used to being respected. She feels stigmatized.
So these give us reasons for us to understand how Angela's fight, flight, or freeze response might easily be activated, right? We have to have compassion for Angela. And at some point in time, maybe give her some insight or make sure that she gets the help she needs to help her get insight into her own behavior. One of the things I've learned in my work is oftentimes people who have experienced lots of trauma don't understand why they're behaving the way they're behaving. They don't know why they're mad or why they freeze or why they don't go to that doctor's appointment. They just don't do it. And help to teach her how to build an environment of safety around her. In summary, we really want you to take home that unaddressed trauma affects our health. A trauma-informed approach is one step toward assisting care respondents on their journey to wellness. And with that, I'm going to return it back to Laura, our moderator. Thank you.
Thank you so much, Karen and Judy. What a lot, so much to cover today. And we're looking right now at the objectives that I reviewed with you at the beginning of this session. And I'd like you to just take a moment and reflect on these objectives and hopefully, knowing that we covered so much today, the impact of trauma and implicit bias on the health and mental health for CARE Act recipients, and the impact of toxic stress and trauma on the brain, and those tips around trauma-informed care approaches that could remove that negative impact of stress and trauma. We're hoping that you walked away with an increased understanding and ability to think through that trauma-informed care approach. And there is more to come in this trauma-informed care series. Let's go to the next slide and talk about next steps here. So we really want to know how we can best support you as a volunteer supporter, or others that have watched this or watching this series as well. You may be a family member, you may be a peer, you may be part of one of the behavioral health agencies or the courts. And please contact our email at info@careact.org. It's up on the slide with any questions. Please join our communications listserv. You'll find that on the website, and use that to submit any requests and feedback for additional CARE Act training or technical assistance. So please also feel free to access the Resource Center website for training decks and recordings of these decks, which will be added 2 weeks after our trainings, and as this one will be uploaded. And we have completed the first of the 3-part trauma-informed care series, really tailored for the volunteer supporter role. We've covered the foundational components of trauma-informed care today, quite a bit to cover. We have part 2, the goals and principles of trauma-informed care, coming up, and part 3, applying trauma-informed care in practice. And finally, going to the next slide, again, I'll just reiterate, there's our website, careact.org, and our email address. So again, we're here to support you and provide you with opportunities to connect and hear about your work in the CARE Act. And with each recording, please feel free to provide feedback on any content today. We would love to hear if you have additional questions and additional impressions and feedback that you would like to share with us. And with that, we will all say goodbye, and we will see you at the next part 2. Thank you.